Hello and welcome to medicsvoices.com, where we talk to the key opinion leaders in health and medicine. Today I'm talking to Professor Jan De Maeseneer, who's been one of the most influential figures in general practice in Europe, in Africa, and indeed now in the US. Jan, take us through your career.
Well, I was born in 1952, so I was part of the baby boomers, and that's important. We were 6 children at home, and we lived in a small house. And the most important thing was that our parents chose that after 4 years in the basic school in the local neighborhood, we could go to what we call the college, to the city, where we had the opportunity to further do secondary training and then finally to go to university. And it's only thanks to the fact that there were a lot of subsidies, financial support for children to go to the university, that we, as the 6 children in our family, had the opportunity to study. So as a student already, it was clear for me, I was a child of May 68. That means I was 16 years old in May 68, and we were very much inspired by this movement. It was about emancipation, it was about participation, it was about finding new content, also for professions. And for instance, the 2 things that were left over from May 68 in our country were, on the one hand, the innovative schools. The other thing was, of course, in healthcare, where we had the traditional model of the doctor, as the French said, on the piedestal, on the top, looking to the patient, and then putting his expertise and his science to help the patient in what was not a horizontal relationship, but rather a kind of patriarchal relationship. I started to be a student. We were involved in social movements, social medical working parties, and we already then questioned the way that healthcare was organized. Already in the 3rd year of our undergraduate training, we made a report to look for a new professional profile that would better suit the needs of society. And what we came up was that the idea of an integrated interprofessional community health center would be a solution. And with students in medicine, students in pharmacy, in social work, in nursing, we already prepared these interprofessional practices during our training program. And very important experience also was that in 1977, my wife and myself, we had the opportunity to go to Rwanda in Africa. And I worked there as a volunteer for 3 months in a community health center. And there I absolutely learned what healthcare means if you have this broader perspective of looking at the community. And for me, that was an experience that inspired very much the way that we started and when we came back, and that we started with our practice. In the beginning, our practice was in the same building as where we were living, and our first child was born there. So my wife and myself, we started a group practice, first with 2, and then it was growing up. Then we had to leave the building because there were more and more spaces needed for the practice. And finally, we established an interprofessional community health center where we have actually family doctors, nurses, assistant nurses, dietitians, health promoters, community health workers, psychologists, dentists, and so on. So all working together, and which is also a place where we invest a lot in training of young trainees, students in all these disciplines. And from the very beginning, when we lived in that society, because why did we choose to work there? Well, we lived as students, we lived in that community, and we saw the problems of that community. And we were there, and we started a community health center. So we had no competitors. There was such a challenge in dealing with the problems: poverty, violence, addiction, different problems in the community, and mainly also the social determinants of health, bad housing conditions, poor income, and so on. Because our community is part of what we call the 19th century belt around Ghent. So there was a historical poverty and deprivation in that environment. And so being confronted with that, we said, well, the place where we should put our ideas in practice is this place. Let's do it here. And that's why we started over there. At the same time in Ghent, different other initiatives came for other community health centers. So we were not alone. We had a kind of movement of creating an alternative to traditional single-handed practices, monodisciplinary practices, just practicing in the fee-for-service system and providing reactive care to the population. And also what we did very early in 1982 already, we went to our National Institute for Health and Disability Insurance and we asked them to change the financing system, because we saw that just fee-for-service does not work to achieve the aims that we had to approach the social determinants of health, to have integrated eco-biopsychosocial approach to patients. So we needed another way of payment. And so we negotiated, and after 1 year of negotiations, we had a new regulation for a capitation system. So we created the environment that enabled us to really achieve the goals that we were looking at. Another important thing was, of course, that we entered very quickly in a dialogue with our local authorities in the city of Ghent, and that was very important as well. So, because as a family doctor, you can make a lot of difference for individuals in their lives. And of course, if I look back at my career, working 40 years in that same community, at certain moments in time, I had the privilege to mean a lot and to give meaning to the lives of a lot of people and help them in important moments in their lives. But I think apart from that, we also have a responsibility when we look at the social determinants and the upstream causes of ill health to invest also in engaging in an advocacy role in our community. And a very inspirational meeting for me was that we organized from 1986 to 2016, then it has been taken over by another initiative, but for 30 years I had the privilege to chair the meeting every 3 months in our community, where all providers of primary care, community representatives, also the local policemen, the local schools, everybody together, 40 people, to come together to make a community diagnosis and to act accordingly. And for me, that was an incredible inspiration, because at that time already I was engaged in an academic career, and I started to work as an academic part-time at the university. And that meeting with the local community for me was absolutely a source of inspiration, because I did not want to lose the contact as an academic also with the patient care, but also not with what happened in this community.
And of course, your own personal research career is fascinating, because your PhD was pivotal in the development of research and indeed primary care in Belgium.
In 1989, I made the first PhD in family medicine in Belgium. There were some other Belgians with a PhD, but that they had from outside Belgium. And that was purely a description and an analysis of 110 GPs encounters, and I took 5,000 encounters that I made an analysis of using International Classification of Primary Care, and to analyze what was the problems doctors were facing and how did they behave, what were their interventions, and also were there explanations to look at interdoctor variation. And a week after the defense of my PhD, I received a letter from our Minister of Health asking me if I was interested to help him to strengthen primary care. And so I went there, and we had a very open chat. And he said, I don't want you to become a member of a political party. I need your expertise and your independence. It took a long time. It took from 1990 until 2002 before the whole population had access to the system, because there were financial implications. The doctor was paid to keep that record, and there was a higher reimbursement for patients. So, finally in 2002, it was generalized to the whole population, and nowadays in Flanders, over 85% of the population has a global medical record with a primary care practice, with a GP.
Your time in Rwanda was clearly very influential, because you invested an awful lot of time and effort and developed primary care in Africa. Tell us a little bit about that.
Yes. In 1995, that was 1 year after the end of apartheid. That was 1994, as you know. I was in contact with a professor, the late Dumo Bakwa, at the University of Cape Town. And we had some interaction, and the professor said, you have to come here to see the coalface of primary care and to look at it here in the African environment. And so I went there for a study visit, and I visited the 7 departments that were then starting departments in those days of family medicine, primary healthcare in South Africa. And it was very interesting. And at the same moment, we were developing an inter-university cooperation in Flanders, working together with all the departments and having one single training program in Flanders in the north of Belgium. And the idea came, let's work together with our network in the north and here these 7 departments in the south. So from the beginning, it was a kind of north-south cooperation, but learning the one from the other. And that was the starting point. And after that, we extended that. We had some funding from the Belgian Development Corporation, and later on from European Union. And we invested that in broadening the network. East Africa joined, Central Africa joined with DRC, Rwanda joined, and so on. And then also North and West Africa. And nowadays, it's still continuing. We have a network of in 25 countries where 45 institutions involved in training of health professionals for primary care, family doctors, GPs, and also nurses are involved in that network. In 2017, the whole organization was completely Africanized. So we are still there, but we are no more the lead. We take no more the lead. We help a little bit and we give advice, but now they are completely independent and they do wonderful things. They exchange programs, they exchange examiners, they exchange training sites. So they really work together, and they are a factor of change in most of those countries. And I never in my life went to Africa to teach something to them because what I could not teach something that's relevant for them. They are better in HIV diagnosis and treatment than I can ever be because they know the problem. So what we really emphasized was, how do you build a community where the primary care can develop? And so a lot was on advocacy, on strategy. A lot was also on strengthening international cooperation, but also on research. A lot of PhDs have been made already in the field of primary care and family medicine. There are GP professors in many countries. Colleges are developing. So yeah, it's still a wonderful experience, and yeah, it's something I look back at with a very positive feeling.
This must be an enormous contrast to your work in the US.
Yeah, in US in 2019, I became an international member of the National Academy of Medicine, and I came in contact with the American Board of Family Physicians, and that was very interesting. People like Larry Green, but also Bob Phillips and all the others. And the interesting thing was that we saw challenges that were common to also the challenges that we face in Africa, and namely, how can we strengthen a primary care system that is responsive to the needs of the population? Of course, in an economical different environment, but also in a divided environment where equity is still a very big challenge, and where there is a lot of problems, for instance, in the way diversity is dealt with. Although the context is different, the same values, the same the strategies are there, and that's linking with local communities, looking at the upstream causes of ill health and trying to find interventions that can make a difference. And of course, when it comes to the human interaction, I had the privilege to sit in consultation rooms, I think in 25 different countries in the world, sit beside a general practitioner. And what I took out of these encounters was, there is so much similarity.
Finally, let me talk about your book, because our colleague Per Kallestrup from Denmark, he described the book as being full of optimism, enthusiasm, and energy. Are you still an optimist?
Yes, Yes, I'm still very much an optimist, and probably that is what I have a lot of energy, but I have also a positive view. Even when things are going difficultly, I still believe that we will find that step, that strategy, that action that can make a difference. And I believe, and of course, I had a lot of very positive experiences that for me increased also my belief that change is possible. But at the same time, it's difficult, and it requires a commitment where you also include engagement with political change processes, with societal change processes. And when it comes to the defense of family medicine primary care, when I have to talk to politicians to convince them about the important role of primary care, more and more I don't only speak about integrated care and addressing the challenges of the chronic conditions and contributing to more equity, but what I try to explain is that primary care and family medicine and general practitioners fundamentally contribute to more social cohesion and to more connectedness. And what a society needs today in order to make political projects to be implemented, projects that improve the conditions of the people to implement them, well, you need connectedness, you need social cohesion. And I'm very much convinced that at the local level in the communities, what we do at the primary care level, SGPs, we are there. We see the needs of the population, we engage with them, and we contribute to building social cohesion, to build this connectedness that our society needs so hardly. And I think that that is the strong point of primary care that makes primary care an important issue and should make it in political strategies.
That is a wonderful note to end this conversation. Jan De Maeseneer, thank you very much for your enormous contribution to primary care and for this conversation today. Thank you very much, Jan.
Thank you.